Well, great. Okay, we're going. All right. Good morning, everyone. It's really my pleasure to introduce our Grand Round speaker this morning, who is Dr. Sunil Rao. Many of us have known Sunil for many years. He's been a friend, collaborator, and mentor to so many of us. He's currently the deputy chief of cardiology at NYU, where he's also the health system director of interventional cardiology. People know that Sunil grew up in Northwest East Ohio, Northeast Ohio. He's an Ohioan through and through, but did most of his training at Duke, where he was a faculty member for many years. And I think we came to know all of his many contributions to science and cardiology while he was there at Duke. Among other things, he has been the president of SCAI and ushered in probably the most successful year of SCAI's recent history, ushering the MATCH program for interventional cardiology, among other things. I first knew about Sunil actually reading the literature that he produced on the importance of bleeding. We used to think about ischemia as the predominant thing that we're thinking about for PCI and for ACS and for STEMIs. And some of his early work many years ago, I remember reading it just early in my training and thought, oh, this guy really is onto something new. And then he followed that with work really being, I think, primarily responsible in the United States for moving us from a transfemoral predominant PCI country to a transradial one. And that's been, I think, one of his great accomplishments and something that he really was one of the innovative people speaking about that and moving the field forward. I followed that as the principal investigator for probably, I think, our only registry embedded randomized clinical trial in the US, which is called the SAFE PCI trial for women, a PCI trial of transradial versus transfemoral access. No more recently doing incredible work on these ACS guidelines. And one of the things that I always say is that I've often asked Sunil for advice. And so it's ironic to see this in the past year, because one of the pieces of advice that he gave me a few years ago was, if you're ever asked to do guidelines, say no. So here we are, and I look forward to hearing what you have to say about the guidelines.
Wow, thanks so much, Bob. That was a really kind introduction. I have to admit that when I was invited to give grand rounds here, I was pretty nervous because, this is sort of the epicenter for clinical research in cardiology. And, you guys are so dedicated to clinical research that you have, see if I can get people jumping out of planes just to publish something. And I was talking to my wife, and I said, did you ever think in your wildest dreams I'd be invited to give grand rounds at a place like BI, and she said, Sunil, you're not in my wildest dreams. So it is a real pleasure to come talk to you about the ACS guidelines. I don't have any disclosures related to this. Any opinions that I express are not the official positions of any of these organizations. And guidelines talks are tough to do, because oftentimes what ends up happening is that you just go through these tables of recommendations. And, you all have read the guidelines. I mean, I don't think I'm going to be telling you anything new. So what I want to try and do here is give you a little bit of a peek under the hood and maybe try to explain the disparity between the advice that I gave Bobby and why I agreed to chair the guidelines. And so what I'm going to talk about is what the guidelines process is, and then we'll go through some selected recommendations from the guidelines. The guidelines actually have their roots way back in the 1990s. So the AHCPR, which is now called AHRQ, commissioned a guidelines document for what was then called unstable angina. And I think we're all recognizing that unstable angina is a vanishing clinical syndrome to some degree. But back then, there had been some clinical trials of antithrombotic therapies. We were thinking about early invasive risk stratification. And I think the government was kind of sick of paying for protocols that were really dependent on who was on call that day. So they really wanted to try and unify the evidence and come up with a series of recommendations. So they commissioned this document. It was helmed by Dr. Braunwald, and Dan Mark and Bob Jones from Duke were also involved in this. And what the importance of this guidelines document was that it established some precedents for how we approach guidelines documents today. So they had science-based methodology. They actually did literature searches to figure out which recommendations are supported by randomized trials, which ones are supported by large observational data and probably shouldn't get a strong recommendation. And then what are areas that we really don't have any data, but we have to come to some consensus on how to approach this. And then, obviously those are going to be areas to do randomized clinical trials in the future. So they did extensive literature searches. And importantly, the document underwent peer review. I think in the past, what was happening was that, some eminent cardiologist somewhere would come up with this is how I like to treat unstable angina, and would publish it in a prominent journal. And people would say, oh yeah, there was a lot of eminence-based medicine. Instead, they kind of came up with this document. They said, this should be peer reviewed, and it was posted for public comment. So the clinical community could look at it and talk about, what actually makes sense and what doesn't make sense. I will tell you, our guidelines document, the ACS guidelines, underwent 2 rounds of peer review. The first round of peer review got 250 comments we had to respond to. And the second round, we had 150 comments that we had to respond to. So it was fairly rigorous. And I think what this addresses is maybe the perception that guidelines are done in a back room somewhere by a group of people who have no expertise because they're not allowed to have industry relationships. And I think that's really, nothing could be further from the truth. Now, certainly the chair cannot have any conflicts of interest that are in industry related, but the committee can. It's, the majority, 51% of the committee can't have relevant conflicts of interest. So there are subject matter experts that are involved in this. And it's a joint effort between the American College of Cardiology and the American Heart Association. And representatives from both organizations, volunteers, are part of the Joint Committee on Clinical Practice Guidelines. Catherine Otto is currently the chair. I'm the chair-elect, so I'll take over this summer. And we have a standardized approach to all guidelines documents. And I'll tell you a couple of changes that have occurred over the last year. The first is we are now focusing specifically on disease states. So for those of you who may have read the 2021 revascularization guidelines, I was part of the writing committee for that. And maybe my experience on there is what led to the advice I gave Bobby. But there will not be an update to that document. All of those revascularization recommendations now are going to be folded into the future ACS guidelines, the future chronic coronary disease guidelines. And so now it's all going to be disease states, and they've reduced the number of guidelines documents by almost half. So they're going to be much more focused and I think much more disease-based. So for every guidelines document, there's a writing committee. And we elect a chair and we have a vice chair. There is a process. There's now, this past year, we actually decided to have a public call for applications. You can apply to be a writing committee chair or a vice chair or even be on the writing committee. There's a kind of an interview process just so people understand, we're not trying to interview them to be chairs, but just so they understand like what they're getting into when they agree to do this, because there is a deadline. And we have to adhere to these deadlines pretty rigorously. I'm proud to say that we were given 14 months to bring in the ACS guidelines, and thanks to the writing committee, we actually met that deadline. The final document was published 14 months after the very first writing committee meeting. And then there's a peer review committee that's completely separate. So they're the ones who will review the document once and usually twice. The other thing that we do is we try to have representatives from other disciplines who may interact with that specific patient. Okay, so for acute coronary syndrome, for example, if you think about who interacts with the acute coronary syndrome patient, well, it's the ED, right? It's non-invasive cardiology, it's interventional cardiology, it's cardiac surgery. And so when we planned this document, 5 professional societies were invited to nominate writing committee members and peer review committee members. There's the American Association of Thoracic Surgeons, the American College of Emergency Room Physicians, the National Association of EMS Personnel, SCI, which is the Interventional Professional Society, and STS. When the document was published, we took some heat on social media, largely by the surgical community, because they said, why are there no surgeons on the writing committee? Well, turns out there were 2 surgeons on the writing committee. My vice chair was Michelle O'Donoghue, but my other vice chair was Mark Rule, who is a cardiac surgeon, and Sigrid Sandner was also part of the writing committee. But they did not officially represent their professional societies. Why? Because the AATS and the STS never responded to the invitation. So they were invited, they just elected not to respond. So ultimately, 3 professional societies were official collaborating organizations on our document. The other thing that's been a relatively recent development is that we have patients on the writing committee, which actually has turned out to be an incredibly important perspective to incorporate. I'll give you an example. On the revascularization guidelines in 2021, we were mired in some argument in the writing committee about a specific recommendation around, I can't even remember what it was. Maybe it was PCI versus CABG, because that's what most of our conversations were. And we were talking about hard endpoints, mortality rates in the trials. And one of the patients on the writing committee actually spoke for the first and only time during that debate. And they said, listen, I've had bypass surgery on 2 separate occasions. I've had 4 PCIs. I don't really care about living longer. I want to feel better, and I want to be able to feel better and go to my granddaughter's graduation. So that kind of shut the debate down because it really is an important perspective. And I think we realized that the audience for these guidelines is not just practicing cardiologists. It's patients, it's non-invasive cardiologists, it's non-cardiologists who read this document. So we do have to pay attention to that. And I think patient perspectives are incredibly valuable. This is the document. I mean, if you haven't read it, it makes great kindling if you want to print it out. I think, I really have to thank the writing committee for bringing this document in on time. There are a couple of other things that I'm going to talk about during the course of this talk, which is what are kind of some of the ground rules we had to adhere to. One of the ground rules is that no section could be more than 200 words. Thank God, right? I mean, I remember the guideline statements, 10 years ago. There were these voluminous documents and no one really had any patience to read them. Now you're kind of forced to be concise. And you can imagine that for some sections, that's probably pretty easy. For other sections, it's very, very challenging to bring that down to 200 words. And then now, of course, we're thinking about, how do we incorporate AI into this? And should we, we actually have a librarian that we employ to help do literature searches. Maybe that can be done through AI. So we're kind of debating that now, but what's going to happen with the future of the guidelines. The other thing we had to do is we had to make some decisions. When I was in training, MI definitions are pretty straightforward. You kind of knew who was having an MI. Now it's not so straightforward. They're like different types of MI, right? I mean, there's Minoka, there are STEMI mimics, there's Takotsubo. And as a writing committee, we said, the randomized trials that we're going to be considering for this document presumed that the patients had a type 1 myocardial infarction. Now, it's entirely possible and likely that some of the patients in these trials probably did not have type 1, but that was the underlying assumption. So we decided to focus specifically on type 1 myocardial infarction. And the other decision we had to make is, do we incorporate unstable angina? Because it's really difficult to find a patient who really fits that profile now with the advance of high sensitivity troponin. So who are the unstable angina patients? Maybe it's the patient who had a PCI last year and they've had a recurrence of symptoms that's so bad they come to the ED. Their EKG is not impressive. Their high sensitivity troponin is not elevated, but you're worried enough about them, right? So maybe that's the unstable angina patient. But again, we elected to include the unstable angina patients in this document. Why? Because the randomized trials included them. So that gives you a sense of what one of the ground rules is. And one of the ground rules is you have to be faithful to the randomized trials. If a randomized trial says that they randomize 6-foot-tall redheads to treatment A versus treatment B, our recommendation has to be worded in 6-foot-tall redheads. So we have to be very, very faithful to that. The other ground rule is the precedent really is important. We cannot revise a previous guideline recommendation unless there are compelling randomized trial data to support a revision. So I can't say, gosh, the previous guideline writers had no idea what they were talking about. I disagree with this recommendation. I'm going to change it. Unless there are randomized trials, I cannot change it. And that will become evident when we go through some of our more perhaps controversial recommendations that we really had our hands tied. So let's try to bring this to the bedside. I mean, this is a contrived patient, but I suspect there are probably some patients in your ED right now that are fitting this profile. So here's a 75-year-old female with some risk factors, AFib. She has dyslipidemia. She's presenting with an NSTEMI. She's got a high sensitivity troponin that's elevated and rising. She's frail. She's 59 kilograms. She's anemic. Hemoglobin's 8.5. She's got a creatinine clearance of 1.6, where if you do the math in your head, her creatinine clearance is less than 30. Normal ejection fraction for the most part, no valve disease. Okay, so let's use this as a framework for how we're going to apply these guidelines recommendations at the bedside. I'm going to talk about some older recommendations that were transferred from the 2014 guidelines. Remember, it's been almost 12 years since the last set of guidelines. We'll talk about selected new recommendations, what we borrowed from recent guidelines, specifically revascularization guidelines. And of course, we've got a whole area of multiple areas that we still need to do a lot of work on. So what's old? Well, I think largely what's old, although it may not be so old in the next couple of years, is antiplatelet therapy and antithrombin therapy. When I was an early faculty member, is really the heyday for antithrombin therapy trials and antiplatelet therapy trials. Thousands of patients randomized, right? So the guidelines have kind of taken that into account. There haven't been any new studies, at least at the time of this publication. So if you've got a patient with non-ST segment elevation MI, who's going to undergo PCI, we really recommend prasugrel or ticagrelor. Note the wording of the recommendations. It's in patients undergoing PCI because the prasugrel trial, Triton TIMI 38 was done largely in patients undergoing PCI, very few patients undergoing medical therapy, and very few patients getting bypass surgery. For medical therapy, there are two options, really. Actually, I'm sorry, there's only one. It's ticagrelor. That's based on the Plato trial because these patients were randomized upstream of the cath lab. So some of them ended up getting medical therapy. Very few went on to get bypass surgery. But prasugrel really is not a recommendation in patients getting medical therapy for ACS. And then, if you're at a center that doesn't have either one of those agents, I mean, can't imagine that's actually the case. But again, our audience may be international. Clopidogrel is recommended. Single antiplatelet therapy with just aspirin is not a good idea in patients with acute coronary syndrome. The bigger question really is, when do you give the agents, right? I mean, this is a debate that we've had for years. At my prior institution, no one was loaded upstream, and upstream meaning before they get coronary angiography. At my current institution, everybody gets loaded in the ED. And if you look at the registry data, it's about half and half. 50% of centers in the US will preload, again, upstream meaning prior to the cath lab, and 50% of centers don't. The downside, of course, is that in those patients who require bypass surgery, it takes a few days for that effect to wear off, and there may be prolonged length of stay. There's not been a single positive randomized trial of upstream therapy. Every trial that's looked at upstream therapy or so-called preloading has been neutral. The only kind of glimmer of positivity was in the Atlantic trial with ticagrelor and STEMI that suggested a reduction in stent thrombosis. So we actually can't give a class 1 recommendation to upstream therapy. It kind of makes sense, right? It's the high risk period when this patient is presenting and their platelets are activated. Let's give them a P2Y12 inhibitor, and it reduces their risk in the first 48 hours. I think the challenge is that most patients are going to the cath lab very, very quickly. So it's very difficult to show a benefit of that strategy because really what you're looking at is kind of loading at time 0 versus loading at 4 hours later. I mean, it's very difficult to show a difference, right? But we gave it a class 2B recommendation. You can certainly consider it. Like I said, it's largely dependent on local practice. Other older recommendations are on antithrombin therapy. I'm not going to go through the coagulation cascade except to point out these 3 agents that upstream of the cath lab, 3 agents get a class 1 recommendation, heparin, enoxaparin, and fondaparinux. I think the only person using fondaparinux probably in the US is Chris Granger at Duke because he led part of the leaders of the OASIS 5 trial. Just a piece of trivia, fondaparinux is the only antithrombin agent that's been shown to reduce mortality in ACS. In the OASIS 5 trial, there's a reduction in mortality compared with enoxaparin. The other studies with the other agents to show a reduction in recurrent MI. ED, of course, loves enoxaparin, right? I mean, you can give it sub-Q. You don't even have to have an IV in. You don't even need to know what the creatinine is. If the creatinine comes back elevated, you just skip the evening dose. But all of the trials kind of show that these are all reasonable alternatives. I suspect that like at our institution, you're probably using a lot of heparin. And then there are separate recommendations when the patient comes to the cath lab. And that's where you see that fondaparinux turns red. It's actually not recommended because in those trials, there was an increased risk of catheter thrombosis when patients underwent PCI on a background of fondaparinux with no additional antithrombin therapy. Heparin still gets a class 1 recommendation. Enoxaparin gets a class 2B, largely because it really hasn't panned out in the PCI population. Trials have been sort of neutral. It's difficult to measure in ACT. It's a little bit cumbersome to use. And bivalirudin was elevated to a class 1 recommendation in STEMI for primary PCI. That's a new recommendation. And that's largely based on this study, which is BRIGHT 4. This is a large trial, 6,000 patients with STEMI undergoing primary PCI. This is done entirely in China, 93% radial access. And the hypothesis behind this, and for those of you who are old enough, you may remember that the early trials of bivalirudin in STEMI showed that there was a slightly increased risk of acute stent thrombosis in the first 24 hours. So the idea was, well, we're not giving enough of this stuff. So in this trial, they were randomized to bivalirudin plus a full dose infusion for a median of 2 hours after the procedure versus unfractionated heparin to try and mitigate this risk of stent thrombosis. Another piece of trivia for the fellows, bivalirudin is derived from an agent called hiruridin. Hiruridin is what makes leeches really effective bloodsuckers. It's a great antithrombin agent. The problem is hiruridin has a half-life of 24 hours. So people bled like stuck pigs when they were given hiruridin in acute coronary syndrome. So bivalirudin is a re-engineered hiruridin and has a half-life of 25 minutes. And in this trial, I mean, look, it's hard to poke holes in this study. There was a benefit of bivalirudin with a post-procedure infusion. Don't let the magnification fool you. I mean, you can look at the y-axis. The rates are low. But there was a difference. I mean, it clearly showed a benefit in all-cause death or BARC bleeding, and there was actually a reduction in stent thrombosis with this. So this is why we elevated it to a class 1 recommendation level of evidence B for patients who undergo primary PCI for STEMI. All right, So now you've got a patient with that non-ST elevation ACS. You sort of figured out their antiplatelet therapy, their antithrombin therapy. When do you take them to the cath lab? It sounds like a silly question, right? Of course, everyone's going to the cath lab. Well, it turns out the data are not so straightforward. Certainly, if someone's unstable, right, they've got ongoing chest pain, dynamic EKG changes, malignant ventricular arrhythmias, they should go immediately. I mean, those patients, I think most of those patients really are circ STEMIs. They're electrocardiographically silent. But what about the patient who comes in with an NSTEMI, elevated troponins? When should they really go to the cath lab? The best trial for this is the TIMAX trial. And it actually didn't show a benefit of early invasive strategy in all patients. It really depends on what their overall risk is, and that was defined by the GRACE risk score. If your GRACE score is above 140, you really should get a routine invasive strategy within 24 hours. If you're kind of moderate risk, I mean, again, really difficult to tease out who this is in the contemporary era, it's really angiography before discharge. And then there's that unstable angina patient, right? It's that person who had a couple of stents a year ago, their symptoms came back, they're worried enough to come to the ED, but their EKG looks okay. The guidelines in this case give you an out. You don't have to cath all of those patients. You can get some kind of non-invasive test. And I think most of us are now getting CTAs in those patients. So, you don't have to cath every ACS patient, but I think in the era of high sensitivity troponins, most of these patients will go to the cath lab. At our institution, they're actually going the same day just because we run our cath labs late. But in other institutions, they usually go within 24 hours. All right, let's go back to our patient. How do we do? So we're going to treat this patient with aspirin ticagrelor, the class 1 for agents, 2B for timing, but I'm going to give us a pass. I think we're going to keep that green. IV unfractionated heparin, pretty good class 1 recommendation. And then we're going to take this patient to the cath lab within 24 hours. It's a class 1 recommendation for routine invasive, class 2A for timing. Again, I'm going to grade on a curve. So we're all green so far. We're doing pretty well. We're adhering to the guidelines and the evidence. So now let's talk about new recommendations in these guidelines. The first one is, what do we do with non-infarct related arteries in patients with acute MI? And I'm sure you guys have probably reviewed this at Journal Club or whatever. This is Shamir Mehta's trial, the complete trial. I was a U.S. national coordinator for this study. It's really, I think, a really, really important study because a sizable proportion of patients with ACS will present with multivessel CAD, especially those with STEMI. And in this trial, we randomized these patients to so-called complete revascularization, a term that I'm not fond of because I think it means different things to different people. Really, it's non-culprit PCI versus culprit-only revascularization. And I have to give credit to Mark Rule, our cardiac surgeon, who pointed out the nuance in this trial, which is that these were patients who were deemed not to be candidates for bypass surgery, okay? Because he reminded me, bypass surgery still has a role in acute coronary syndrome. So, I think you all are familiar with this trial. It showed that the so-called complete revascularization strategy resulted in a lower risk of cardiovascular death or new MI over a follow-up of 5 years. And also the second co-primary of cardiovascular death, new MI, or ischemia-driven revascularization. So in our algorithm in the ACS guidelines, if you have a patient with multivessel CAD who's hemodynamically stable, and they have low complexity multivessel disease, that is, you think they're a good candidate for PCI, you should do PCI of those non-culprit arteries to reduce their risk of MACE long-term. The question is, when do you do it, right? Do you do it all at the same time? Do you do it in a staged fashion? These data are evolving. When we looked at the data and, before the guidelines came out, we felt that there wasn't a strong body of data to support doing it all at once. So we gave it a 2B recommendation. Now, I think the data look a little bit different. The staged approach might actually be more beneficial if you look at kind of the pooled data. So we'll see what happens with the next iteration of the guidelines. I, for one, am very happy that we don't have to do multivessel PCI in the middle of the night. I think it does give you a chance to sort of let these patients settle out and do this in a staged fashion. Certainly, if they've got very, very complex disease and you think they're a good candidate for bypass surgery, that also is a recommendation. What about NSTEMI? So this gets a little complicated for a couple of reasons. The first is I actually argued that we shouldn't use the term non-culprit PCI in NSTEMI. And the reason is that my colleague, John Heitner, did a great cardiac MRI study that he published in Circ Interventions a few years ago, where he did cardiac MRI on NSTEMI patients who underwent PCI. And what he showed was that 25% of the time, we're stenting the wrong artery. What we think is the infarct artery, in fact, is not the infarct artery. So how do you know? Obviously, in STEMI, it's easy, right? Arteries occluded. In NSTEMI, it's much more complicated. And I preferred the term multivessel disease in NSTEMI, but I was outvoted. It's a democracy, I guess. And I was outvoted just to keep the language consistent in the guidelines. We decided to use this non-culprit term, but just be aware. Sometimes what you think you're stenting is not what you're stenting. And we gave it a class 1 recommendation because we felt that the bulk of data supported a complete revascularization strategy, even in NSTEMI. And I think that the issue here is not when you do it, it's what do you use to guide your strategy? Should you use physiology or should you use angiography? And it's very interesting. I mean, if you look at the data, clearly physiology is the way to go in a patient with chronic coronary disease. In ACS, I'm not so sure. The trials have been neutral. Even the ischemia trial, which is largely a chronic coronary disease trial, what determined the outcome was the anatomical burden of disease, not the degree of ischemia, which makes you scratch your head a little bit. Maybe there is a difference in how coronary physiology responds in the setting of an acute MI that either fools us and then there are, of course, these vulnerable plaques that are non-obstructive in patients with acute coronary syndrome. These patients have already demonstrated they've got plaque rupture. So, physiological assessment was given a class 2B recommendation in the current iteration of the guidelines, but this trial may in fact change the next iteration. So this is complete 2. This is also being led by Shamir Mehta. I'm on the steering committee for this trial. It's the 5,000 patients. I think we're about 1,500 patients in. These patients have multi-vessel disease with STEMI or NSTEMI, and they're being randomized to either a physiology-guided strategy or an angiography-guided strategy. It'll be a few years before this trial comes out, but I think this will be very informative to the next set of recommendations. And then there's danger shock, right? This trial really, I think, was a landmark study. It started out as the Dan shock trial. I think they chose Germany so they could make a danger shock. It kind of fits nicely. No, Germany has a long history of obviously doing trials in shock, but 10 years to randomize, 300 plus patients, very difficult. I think this shows how challenging it is to do trials in cardiogenic shock. And these patients, as you all know, selected cardiogenic shock patients randomized to get the microaxial flow pump, mostly the Impella CP, versus usual care. And a couple of interesting notes about this trial. So we'll talk a little bit about IABP shock too, but when that trial came out, the protocol was amended so that balloon pump was not recommended in the standard of care arm. But when the culprit shock trial came out, looking at non-culprit disease, they didn't change the protocol. So it's a little bit curious. I mean, I think it also goes to show that maybe it's difficult to have equipoise in certain aspects of shock care. But as you know, this trial showed that there was a significant absolute 13% reduction in 6-month mortality with the use of the microaxial flow pump. These investigators really learned some great lessons from prior shock trials. The first thing they did was that they selected their patients carefully. So comatose patients were excluded from this trial. In a lot of the trials like IABP shock 2, particularly culprit shock, there were patients who were comatose that were allowed in the trial, and a proportion of the patients in culprit shock didn't even have ST elevation. And it's possible those patients, nothing you did was probably going to help them. So they may have driven the sort of neutral results. These were patients that were not comatose. They could be resuscitated from cardiac arrest, but they were not comatose. The other thing that these investigators did was that they made the primary endpoint at 6 months. Remember, the original shock trial that led to the widespread adoption of the class 1 recommendation of primary PCI for cardiogenic shock, the 30-day endpoint was neutral. It was the 6-month endpoint that was positive. And that's probably because there's a whole bunch of stuff happening in that 30 days. And in fact, if you look at the distribution of deaths in this trial, most of them occurred within the first 48 hours, probably from the initial insult. And then a bunch of them happened after 30 days. And that's probably from sepsis, pneumonia, pump failure, a variety of different things. And one of the arguments that was put forth for explaining kind of the complication rates from the microaxial flow pump was that patients live long enough to get them. But at the end of the day, these are the data. And if you also go back and read the original shock trial data, the absolute risk reduction at 180 days with primary PCI and shock, 13%. So it's a little spooky. It's the exact same absolute risk reduction. And there is obviously a price to pay. I mean, I think these are real complications. I mean, bleeding is high, renal replacement therapy is high, sepsis is high. The other thing is that the protocol in this trial, they ran the microaxial flow pump at P9 for 48 hours. That was protocolized. I'm not really sure that all of us are doing that anymore. I mean, I think we're trying to get these devices out as fast as possible. Some of you may be aware of the AHA shock registry. I was one of the founders of that registry. We've actually set that registry up to do randomized trials. There are discussions about doing a randomized study to look at kind of a rapid hemodynamic driven weaning protocol versus the danger shock protocol to see if we can reduce the complication rates. So hopefully we'll be able to get that trial off the ground. But what about other MCS? And, look, every time I give this talk, this is probably the one recommendation that people really have a problem with, which is the class 3 recommendation for ECMO and for IABP. And I will tell you that I agree with that, because we've all had patients, when you put a balloon pump in, you open their artery, they turn around, right? They do better. There are patients who get VA ECMO and they walk out of the hospital, right? So, but again, I will remind you that we have to adhere to what the ground rules are. We can't change the recommendations based on prior guidelines, and this is what was in the REVASC guidelines. Also, the wording is important. So the routine use of balloon pump or the routine use of VA ECMO is not recommended because of no benefit. And I think that's probably a reasonable recommendation. If your entire shock protocol says you always have to use a balloon pump, maybe that's not the right thing to do. But again, this is a situation where clinical judgment has to complement the guidelines recommendations. We're still using balloon pumps in selected patients. We're obviously using ECMO in selected patients, but it's not our routine strategy for patients with cardiogenic shock. When the REVASC guidelines came out, we took a lot of heat at the interventional meetings because we didn't give intracoronary imaging a class 1 recommendation. And, I won't go into the background of why we gave it a class 2A, but remarkably, in the 3 years between the release of the revascularization guidelines and when we started the ACS guidelines, there were 3 trials published showing that intracoronary imaging reduces mortality. So we can't ignore that, right? So this is why now in the ACS guidelines, a new recommendation is that intracoronary imaging, and it doesn't matter if you use IVUS or OCT, we had a little bit of debate and there was one neutral OCT trial, but we felt that in general, the bulk of evidence supports intracoronary imaging. And the wording, again, is important. Left main or complex lesions, why do we use that wording? Because that's what the trials used. These trials were able to show a benefit because the disease was complicated. It's very, very difficult to show a mortality benefit when someone has a type A lesion. In fact, most of those probably should be treated medically. Does that mean you shouldn't use imaging in type A lesions? Absolutely not. It just means that the recommendation has to be worded this way because that's what the trials do. Clearly, I think it's the era of intracoronary imaging guided PCI, and the bulk of evidence supports that. I can't do a lecture without talking about transfusions just because I have an interest in that. And, Kaylin was a part of the MINT trial as well. And this is, the largest randomized trial of transfusion strategies in patients with acute MI, led by Jeff Carson, which is really his life's work. It's funded by the NHLBI. This was done during COVID and really remarkable success, despite the fact that it was difficult to enroll. This is 3,500 patients with STEMI or NSTEMI and a hemoglobin less than 10, randomized to keep their hemoglobin at 8 versus 10. This is a tough trial to do, and these patients were really, really sick. Why? Because MI patients don't stay in the hospital long enough to get anemic anymore. They're all going home like within 48 hours. So who's anemic now? They're elderly. They've got a lot of comorbid conditions. They've got lung disease. They've got renal disease. All of those patients were allowed into the study. And I think in the interest of world peace, Jeff specifically coded the liberal arm as red and the conservative arm as blue. But we just barely missed nominal statistical significance with this particular trial. It was a surprise to me. I was pretty sure that liberal transfusion was going to be worse, but all the endpoints trended in favor of this liberal transfusion. But it wasn't a solid home run. So we're still left with some questions about what the role of transfusion is. My thoughts are that in general, it's probably better if a patient is symptomatic from anemia and you've worked up the source of their anemia and they're not having any kind of bleeding issue, that it probably is better to maintain a higher hemoglobin. And we gave that a class 2B blood transfusion to achieve a hemoglobin level of 10 or greater is reasonable. And I think that's probably the right recommendation. I think a class 1 recommendation probably overstates what the evidence is. And clearly it's going to have implications for the blood supply and other kind of societal issues. All right. Discharged antiplatelet therapy. This was a very, very challenging section. Remember, you had to keep it to 200 words. And so many different trials. I really have to give a lot of credit to Usman Babar, who wrote this section. He really did a terrific job. What we're really talking about here is when is it safe to de-escalate therapy, right? In general, all of the trials have used 12 months or more. So the foundational strategy is still 12 months. That is, all things being equal, patients should be treated with 12 months of DAPT. But there are times where you may want to reduce that by de-escalating. And you can de-escalate in multiple different ways. You can reduce the potency of the P2Y12. You can get rid of one antiplatelet agent, or you can truncate the therapy. So those are kind of the 3 big strategies, right? There are 2 of those that get a class 1 recommendation. The first is, going from an aspirin ticagrelor strategy to just a ticagrelor monotherapy strategy at 90 milligrams BID. That's the Twilight global leader strategy. And we gave that a class 1 recommendation. Certainly, if someone's treated with an oral anticoagulant, all of the data say that aspirin is really unnecessary and probably harmful. When do you stop the aspirin? In the dabigatran trial, they stopped it the day after PCI. In the apixaban trials, they kind of kept it on for a little while. My former colleague, John Alexander, did a very nice kind of statistical analysis of the apixaban data, suggesting that maybe 2 weeks of triple therapy is what's needed to reduce the risk for stent thrombosis. We said 1 to 4 weeks, and I think probably what you all do is what we do. And someone says, how long should I treat this person with aspirin? We go look at the films. Right. And you say, well, this is kind of a complicated case, a lot of stents, bifurcations. Maybe you keep the aspirin on for a little while. Or you say, gosh, this person's 90 years old. They're very frail. Just stop the aspirin from the get-go. So, there's some nuance here in how you may interpret these. Other strategies have not necessarily been supported. So they kind of can be considered. So you can decrease the potency of the P2Y12 going from something like prasugrel, ticagrelor to clopidogrel. Or you can go to a monotherapy strategy with clopidogrel alone or aspirin alone. So Josh Beckman, who was the chair of the Joint Committee on Clinical Practice Guidelines when I chaired this document, said to me, one of the challenges your writing committee is going to have is determining when an ACS patient becomes a CCS patient. And so as a writing committee, we decided to deal with that issue head on by not dealing with it. Because I have no idea when that happens. I mean, and I think it's probably different for every patient, right? So look, I think the bulk of data now probably suggest that a clopidogrel monotherapy is superior to an aspirin monotherapy. And there's going to be 10-year follow-up of host exam, which is the trial done in Korea that's going to be presented, I think, at PCR. So we'll know what happens with long-term therapy. But I suspect that these recommendations will change in the next iteration of the guidelines based on the data that are coming out. So stay tuned for that. All right, let's go back to our patient. So we're doing pretty well so far, right? What else did we do? Well, we're going to work up her anemia and give her a transfusion. So that's 2B, not terrible. If she gets a PCI, we're definitely going to use intracoronary imaging. It's a class 1 recommendation. And if she has multivessel disease, I'm going to punt. I'm going to enroll her in complete 2. So we're not going to give ourselves a grade on that one. So far, okay. We've got 1 orange box, but by and large, we're green. What do we borrow from recent guidelines? And really, we borrowed things from the revascularization guidelines. The first thing that we did was we took the radial approach recommendation. I think where radial approach really does have a benefit is in patients with acute coronary syndromes. The pooled data show a reduction in mortality, a reduction in bleeding complications. So we transferred that over to the ACS guidelines, giving it a class 1. And then we transferred over the recommendation for non-culprit disease and shock. We talked about non-culprit disease in the stable patient. What about the patient in shock? The hypothesis, of course, is that if you're having a STEMI, that part of the myocardium where the vessel is occluded is obviously compromised, right? So if you've got other disease, maybe opening that will sort of help overall LV function, improve outcomes. In the culprit shock trial, though, this did not pan out to be the case. In fact, multivessel PCI was worse. Now, it's multivessel PCI at the time of primary PCI. This trial does not say you should never do it, but the outcomes when done all at the same time were worse. And so this ends up getting a class 3 recommendation harm. And again, there's some nuance here. Once the patient is stabilized, I think it's entirely reasonable to do non-culprit PCI, whether it's in the hospital before they go home or in a staged fashion. Many of you may have seen the post hoc analysis from Danger Shock, where they looked specifically in an observational way, the relationship between doing non-culprit PCI and shock and outcomes. And this is what I mentioned, they didn't change the protocol when this trial came out. And I think they didn't change it probably because the investigators didn't have equipoise. Some of them probably felt like they should do multivessel PCI. And that analysis from Danger Shock showed that there was an association between non-culprit PCI at the time of primary PCI and a significant reduction in 6-month mortality. Now, it's observational, and the degree of benefit was greater than the benefit shown with Impella. So there are clearly some confounding factors here. But kind of the scary thing that this points out is the question of whether we need to repeat all of the shock trials and use a Danger Shock-like population. Because maybe there are selected patients in a randomized fashion where we can show a benefit of these strategies that, according to the published literature so far, either have no benefit or harm. I don't know who's going to fund that, and I don't know how it's going to be very challenging to do that. But, I think that this area of how to treat cardiogenic shock is rapidly evolving. And, I hope that we've got more data to inform future iterations of the guidelines so that most of us who are seeing these patients are not left in the dark about how to treat them. So here's what we did. We did left radial access in this patient. She's older, and so it tends to be less left subclavian tortuosity. She's a relatively clean LAD lesion that we did IVUS-guided PCI with a very satisfactory result. But, look, we're not done yet, right? I mean, this patient has gotten in-hospital treatment, but she's got a lot of stuff left to do to reduce her risk. For many of these patients, the first time they've had coronary disease, right? So they're on multiple meds when maybe they weren't on any medications previously. They need education about when they can go back to work, when they can exercise, when they can travel. I've circled annual influenza vaccination. This actually gets a class 1 recommendation based on the large trial done in acute MI patients in Sweden. And cardiac rehabilitation is incredibly important. It's a class 1 recommendation. This was really interesting when we talked about the influenza vaccination recommendation, because we were smack dab in the middle of, I don't want to call it a vaccine controversy because in my mind, it's not a controversy, but sort of a ginned up vaccine controversy publicly, right? And so we debated, should we make a recommendation about vaccines in general? And ultimately we decided, that's not really our purview. What we have are randomized data in acute MI patients with influenza vaccination. There's a lot of stuff that patients should be getting, right? Colonoscopies, they should be getting that, right? So do we need to mention that in the guidelines? So we decided not to address that. But it shows you some of the challenges, right? I mean, you have to kind of draw a line in the sand of what you're going to recommend based on the trials versus what common sense and probably good medicine in general tells you to do. But ultimately, again, we adhered to the randomized trials and we specifically mentioned influenza vaccine. So what do we do for her? We discharged her on antiplatelet therapy, a P2Y12 plus a DOAC, because remember she had AFib, that's a class 1 recommendation. And of course, aggressive secondary prevention, including cardiac rehabilitation. In the last few minutes here, I want to make a few selected comparisons with the ESC guidelines. We're all looking at the same data. So why don't we just come up with one guideline statement for everybody? I won't delve into the politics of all of that, but I think for the most part, we're pretty consistent with the ESC. There are some slight differences, and I've pointed some of those out for you here. So for example, in revascularization, the ESC combines the recommendation for non-infarct artery and the timing into one class 1 recommendation. They just say you should do it in a staged fashion. But they do parse the timing of non-infarct related artery in patients with shock. They say that they have 2 separate recommendations. They say, it's a 2A recommendation for stage. We just put that in the text and said, don't do it at the time of primary PCI, do it in a staged fashion. They also gave a 2A recommendation to non-infarct related artery PCI and NSTEMI. We gave it a class 1. I'm not sure who got it right. I think, now there are trials now in dedicated ACS patients looking at, dedicated NSTEMI patients looking at non-infarct PCI. What we were faced with is that these patients that were in these trials, some of them had STEMI, some of them had non-STEMI. So we were kind of forced to look at the overall body of data, even though the NSTEMI was a subgroup. With respect to DAP, they gave a preference to prasugrel over ticagrelor based on ISAR React 5. We elected not to do that. It's one trial that we had some issues with the way the trial was done. It was unblinded, et cetera. It's a very, very strong study. And I certainly cannot argue with the ESC guidelines. And we probably aren't using enough prasugrel, quite frankly. It is generic. ESC did not give a class 1 recommendation of the ticagrelor monotherapy strategy, whereas we did, the Twilight and the global leader strategy. And then they specifically gave guidance on how long you should use triple therapy in patients who are on oral anticoagulation. They gave a class 2A recommendation for 1 week to 1 month. I have a little bit of an issue to giving a recommendation to a range. I wish they were a little bit more prescriptive. Remember, we just put it in the text and said 1 week to 1 month. And then for secondary prevention, they specifically targeted an LDL less than 55. We said if you've got an LDL of 70 or greater, you should push that a little bit lower. We use the term non-statin alternatives because we think ezetimibe is a reasonable option. They specifically said that you should use PCSK9 inhibitors. So overall, we were pretty consistent. In fact, Robert Byrne, who wrote the ACS guidelines for the ESC, was really a valuable source of kind of just a sounding board for me during the writing process. Just sort of dealing with different recommendations and how do you deal with controversies and how do you actually settle debates. He's sort of an expert at that. So I do have to thank him for that. We have a lot of work left to do. And I think we should all congratulate ourselves that we have so many randomized trials. But, the ground is shifting beneath our feet. We now have a plan to update these guidelines in a regular fashion. It won't be 12 years to the next ACS guidelines, I guarantee it. There's a regular schedule for where these documents are updated. So we're going to have to figure out, what about these new antiplatelet agents, selatogrel, zolunfiban? What about anti-inflammatory agents, ziltivekimab? What do you do with multivessel PCI versus culprit only and STEMI? And physiological guidance. Complete 2 will tell us that. Lots of new mechanical circulatory support devices. Bobby's been involved in a lot of these. They're being studied in high-risk PCI, but maybe they'll have a role in shock as well. And then again, this big question of when do you transition from acute coronary syndrome to chronic coronary syndrome, and what is the best antiplatelet strategy long term? So a lot of things left to do. And I'll end really with addressing another criticism of the guidelines. And Alex Faneroff, who was a fellow at Duke, wrote this paper in 2019. And I didn't take this really as a criticism of the guidelines. It really was kind of a criticism of our profession. That at that time, the 2014 NSTEMI guideline, only 15% of the recommendations were level of evidence A. More than 50% were level of evidence B, and a full third were level of evidence C. And I think this was kind of a wake-up call that we need to continue to do randomized trials. I'm happy to say that the latest iteration of the guidelines has gotten better. So 27% are level of evidence A, and only a fifth are level of evidence C. And 2/3 of our recommendations in this document are based on randomized trials. So we're doing a lot better than we did, but we still obviously have a lot more work to do. So I'll wrap up here. We'll have time for questions, comments, and criticisms. The 2025 guidelines really are a good summary of evidence to improve outcomes, but they have to be applied with clinical judgment. These are not commandments. They're summaries of evidence, and you have to tailor these recommendations to the patient that's in front of you. This includes, contemporary randomized trials across the treatment spectrum. The foundational strategies are still the same: antiplatelet therapy, antithrombin therapy, and early invasive risk stratification. But we've included a lot of new recommendations. I pointed out some selected ones: multivessel disease, anemia transfusion, intracoronary imaging, and cardiogenic shock. I said the next challenge, but this has always been the challenge, right? How do we implement this stuff? And it seems like just as we're implementing the one set of guidelines, a new document comes out. But I'm hopeful that in the current era of electronic health records, I'm sure you guys have a huge effort related to AI and how you can actually make our lives a little bit easier and make patient outcomes better. We're doing the same thing at NYU. How can you use that to translate these recommendations into clinical practice much faster so that we can actually start improving outcomes as soon as these guidelines come out? I really have to thank the vice chairs, Michelle O'Donoghue and Mark Rule. Michelle O'Donoghue was really a pleasure to work with. She has an encyclopedic knowledge of clinical data and is incredibly detail-oriented. The ACC AHA staff, who kind of kept us on task. The writing committee, who really did a great job. Even during the holidays, they were turning in their sections on time. And of course, the peer reviewers. So again, I want to thank you for the invitation to come here. It's really been a huge honor for me, and I'm happy to take any questions or comments.
Comments and questions?
Yeah, Kaylin. Yeah, it's a great question. So, we didn't address the whole issue around testing because I think the data have not really strongly come out in favor of testing either phenotype or genotype with respect to platelet therapy. The only one that I think that's probably a good study is Popular Genetics, where they looked at STEMI patients and de-escalated based on whether they were responders or not. They were kind of de-escalated from potent P2Y12 to clopidogrel. I think in that particular case, don't ever get a test unless you know what you want to do with it, right? So if you've got those data, I think you're compelled to do something different. Prasugrel monotherapy has not really panned out. And in the trials that were done largely in Southeast Asia, they've looked at prasugrel monotherapy and it's not been beneficial in patients with ACS, with the caveat that they use some funny dosing. Like one of the trials, I think, used 3.75 of prasugrel. I don't even know how you get that, really. So I think in those cases, I would probably change to a ticagrelor monotherapy strategy, where you get definitely a platelet reactivity. Yeah, Jamie.
Reflecting on all the various parties that you got involved, that's wonderful. But as an operator, one of the more uncomfortable with the interface with guidelines in legal settings.
Yes.
And you have guidelines that say, in routine practice, this, that, and the other.
Yeah.
But obviously, for an individual patient, it isn't routine.
Right.
Individualized. And I think a lot of us have, in the deposition or expert witness, someone says, well, the guidelines say this is harm. How did you?
Yeah.
So do you ever consider incorporating kind of a legal reference, some kind of oral community?
That's a great question. And it comes up all the time. Oh, yeah, sorry. The question was around kind of the legal implications of these guidelines recommendations, and are you at risk if a particular patient that you're treating, you don't completely adhere 100% to the guidelines? And it does come up. So far, we've not done that. And I think largely because oftentimes these legal issues come down to what is considered local standard of care. And there have even been very, very high profile legal settlements against physicians who have adhered to the guidelines. In fact, there's a great editorial, I think it might have been in JAMA or the New England Journal, where the title of it is Evidence-Based Medicine on Trial. And it was really around prostate cancer, and a patient was screened for prostate cancer, where the physician adhered specifically to exactly what the guidelines recommendations were. And the patient ended up with prostate cancer, and they sued and they won. So I think the problem is this sort of local standard of care. It turns out in that community that the physicians did exactly the opposite of the guidelines. And that physician was, didn't, according to the jury decision, didn't adhere to the local standard of care. So I think it's hard in that setting to kind of be all things to all people. So we elected not to do that. It's a great question because it comes up largely around MCS and these very, very sick patients who have cardiogenic shock. If you've got a recommendation that says no benefit and you do it and the patient has a complication, what are you at risk for? I don't know that I have a good answer to that. And I guess what I would continue to do is to hammer home the point that these are summaries of evidence and they have to be exercised with clinical judgment. But, your point is a good one. It may come to the point where we have to do that. It'd be a sad day, but I think, it may happen. Yeah. Oh, yeah. Yeah. Terrific questions. Yeah. That's terrific. Those are great questions. I've never had those questions before, I have to say. Those are really good questions. The first one, to repeat the question is, we can't change recommendations based on new data, but what if other things about the trials come to light? Does that affect our recommendation? And the second question is, do we take into account the context in which the geographic context in which the trials were done? So the answer to the first question is, unless the trial's been retracted, we really don't consider that. And I think that's, if there's a full retraction, then you clearly cannot, account for that. And we'll have to take that into consideration in changing the recommendation. Clearly, the Plato trials had some controversy. I'm not entirely sure those comments or the criticisms were justified, and the trial hasn't been retracted. So we elected to keep that. With respect to your second question, absolutely, the geographic location does come into play because particularly in areas of the world where there may be different genetic responses to antiplatelet therapy, how do we incorporate that? And generally, the discussion focuses really on whether we should downgrade those recommendations when it comes to, the context of North America or Europe. But in the end, it doesn't play as much of a role as you would think. And the reason is that we can't tell exactly who our guidelines apply to, right? We think it's largely a North American audience, but that's actually not necessarily the case. And there are areas around the world that incorporate the ACC/AHA guidelines in their treatment recommendations. The other issue is that I think that with respect specifically to antiplatelet therapy, although I know that wasn't specifically your question, there does seem to be a disparity between the genotype for antiplatelet therapy responsiveness and the actual clinical outcomes. I mean, that part of the world has a higher prevalence of the genotype that results in clopidogrel hyporesponsiveness, and yet they have the lowest reported rates of stent thrombosis in the world. People have argued maybe that's because they do routine IC imaging, but I guess my interpretation of that, it goes to show you that there are other things involved in stent thrombosis than just the pharmacotherapy. Great, that's a great question. Yeah. 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 Yeah, so the question is around coma and MCS in these shock trials. So in the dangerous shock trial, they use a Glasgow coma scale. They were specifically using that as an inclusion or exclusion criterion. in that. And I think that's probably what most of us are doing now, just largely because I think danger shock is probably the only trial that's going to be done. I was trying to incorporate that. I mean, it's not easy, right? It's not easy. I think in the throes of taking care of these patients, it is difficult to play the role of the interventionalist who says no. Because at the end of the day, the team that's taking care of the patient says, we have to give this person a chance. And you're coming in saying, for reasons X, Y, and Z, it is unlikely this patient is going to survive. And that's a difficult position to be in. And, we have a pretty mature shock team at NYU. We have those discussions all the time. And, I'm not entirely sure that we know the right answer, but there have been situations where I think as a consensus we've come to that we may be doing more harm than good by using MCS in specific patients. Yeah. Yeah. Right. Yeah, thanks so much. So the question is, to what degree does cost and affordability come into the guidelines? So traditionally, it has never entered the guidelines because the idea was that we're kind of these vaulted physicians who are making the best evidence-based decision for the patients, and other people can kind of figure out if the patients can afford it or not. And gosh, there's just so much difference in the price of this, that, and the other, but that's changed. So now I think, Kazi, you're involved in this. So this is the cost is going to be a big part of some of these recommendations. And that is, I don't envy you. I mean, it's a challenging role to play because, balancing cost and affordability issues with what the data are. The traditional view, and I was being a little bit cynical when I was kind of mocking that, but the traditional view is that the guidelines are not about implementation. The guidelines are about the evidence, and the implementation is a separate aspect. So if, let's say the guidelines recommend a certain strategy and your hospital says, well, we don't have a protocol for that. The response has always been, well, that's up to you guys. Like, you have to figure that out. For cost and affordability now, though, that's a little bit different because it really does significantly limit whether or not certain patients can get the best care. And in some situations, we may actually be doing them harm, right? If you prescribe them dual antiplatelet therapy, for example, that they cannot afford and cannot take, you are effectively not treating those patients. And so now I think it is a good idea to incorporate that. And I'm glad that you're involved in this, guys, because you're the best guy to do it. Yeah. 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 It's great because the question is that, we do have kind of a wealth of data in acute coronary syndrome, and there are areas of cardiology like ventricular arrhythmia, sudden cardiac death, where maybe there's less data available and hard to do randomized trials. It's a great question. I'm not sure that I have an answer for you. I will tell you that, for better or for worse, a lot of our trials are driven by industry. And, that's something that we discuss all the time. I mean, NHLBI just doesn't have the resources to be able to do these large trials. We have to do the trials with other sponsors. And, there are ways to manage those conflicts when you're doing it. I mean, I've certainly done industry-funded trials, and we try to be as honest as possible. But I do think this is, in my mind, a larger question for society as a whole, which is, in an environment that is getting extremely challenging for research funding, and there's a finite pie, how do we move forward and generate new evidence? We've been talking about pragmatic trials for 20 years, and I think we're starting to see more pragmatic trials. But I think that we have to hit an inflection point at some point where we really have to be able to do these pragmatic trials for low cost and answer these important questions that come up. And I think that, ventricular arrhythmia, sudden death is a great area where I think we should focus on because we don't have great data on how to deal with these things. And maybe the solution is going to be health systems coming together and unifying their EHRs. You actually can randomize now with an Epic. Maybe that's the solution, because the other thing that's going to suffer if we continue to go to government agencies to fund these trials is that discovery science is going to be compromised. I mean, the ischemia trial was $150 million, right? And it was led by NYU. It's a great study. I think it has formed clinical practice. But if you put your other hat on and you say, how many R01s could have been funded by that in the discovery space? So we have to think about those kinds of things. And it's a great, I don't have a solution, but I think it's getting more and more urgent that we come up with something as a clinical community.
It's interesting from my standpoint that, the ACS is probably, is there a disease process that is better studied than ACS? It probably is the most studied disease that we have.
Yeah, maybe with the exception of some cancers, but yeah, I think cancer is and
trials. No, I mean like a single entity.
Yeah, I think that there are lessons to be learned from the oncology community, though, right? Because every patient gets enrolled in something, and they've got these networks, and some of that has been a governmental mandate, certainly. But you're right. I mean, ACS, we have so many trials in ACS.
But it's sobering that even then, your pie chart is not filled with buffet guidelines.
Exactly.
We're not nowhere near sort of the asymptote. What we need to learn.
Yeah.
Anyway, well, thank you, Sunil. That was just an unbelievable talk.